Hello, welcome to my learning channel, MLS QR. Quick review for ASCP Board of Certification exam for MLS, CLS, and MLT candidates. Today, let's get a quick overview of anemias and RBC morphology. As a clinical laboratorian, let's go into the definition of what is an anemia and what are the anemias, and let's see the diagnostic approach for the healthcare provider. A functional definition of anemia is a decrease in the oxygen carrying capacity of the blood. In the clinical lab, an operational definition is a reduction in the RBC count, hemoglobin concentration, and hematocrit below the reference range for healthy individuals. So, symptoms prompt the patient to go to the doctor complaining of fatigue, weakness, and shortness of breath. The healthcare provider will obtain a detailed history of the symptoms as well as diet, meds, occupational hazards, bleeding history, last workup, and any other pertinent details. And then proceeding to the physical exam, the vital signs are taken with cardiovascular and pulmonary systems examined, as well as skin color, sclera, conjunctiva, oral mucosa, lymph nodes, spleen, and liver. The initial anemia workup includes CBC with differential and peripheral blood smear exam if indicated, as well as the retic count. The screening test for CAM panel, coag panel, and UA may follow as well. Using a microscope or a digital microscope, the hematologist will observe for any RBC abnormalities and denote few, moderate, many, or slight, moderate, or marked. Observation for these red cell abnormalities provides valuable diagnostic information for the clinician. In the CBC definition anemia, we pay attention to reference ranges, and they vary from medical center to medical center, male greater than female, and the pediatric population, the neonates start out high and they decline till age 3. So there's a lot of variability. But let's use the ASCP reference ranges. So this is the reference range that given by ACP Board of Certification, 7th edition, and RBC count is less than 4 million per microliter or lambda, hemoglobin less than 12 grams per deciliter, hematocrit less than 35%, and pay particular attention to MCV, which is stated as 76 to 100 femtoliters, and be familiar with the units as well as the values because you will be required to have them as part of your knowledge to answer the questions in the AACP Board of Certification exam. I included retic count and NRBC values as well. It is important for the healthcare provider to get a baseline CBC and see progression of the anemia through time and the effect of treatment and transfusions. There are several ways to classify anemias, but a very nice, clean way is to classify the anemias based on the patient's MCV, microcytic, normocytic, and macrocytic. And we're going to use the ASCP ranges of 76 to 100 femtoliters. So looking at normocytic, you want to see the retic count, is it increase or decrease or normal? And if it's increase, this points to a hemolytic anemia. And there are intrinsic and extrinsic hemolytic anemias. So as you can see here, we want to see the intrinsic. These include the hemoglobinopathies, sickle cell anemia, SC, hemoglobin CC. It includes membrane defects. We're going to go into that in another video later, and enzyme deficiencies like G6PD and pyruvate kinase deficiencies. So these are the intrinsic hemolytic anemias with a high retic count. In the blood bank, you'll encounter hemolytic extrinsic anemias involving an antibody. Autoimmune hemolytic anemias include those caused by the antibodies KAL, Duffy, KID, and other RH and other antibodies that are uncommon, as well as warm autoantibodies and cold agglutinin disease. Hemolytic transfusion reactions could be caused by any of those antibodies, as well as ABO incompatibility. And there is the hemolytic disease of the newborn, which is caused by antibody from the mother going to the baby. Normocytic, hemolytic, extrinsic anemias that are non-immune include microangiopathic anemias, thrombotic thrombocytopenic purpura, hemolytic uremic syndrome, disseminated intravascular coagulation, as well as infectious hemolytic anemias, and those that are caused by drugs, chemicals, venoms, and severe burn injury. The classic infectious hemolytic anemia is malignant malaria caused by Plasmodium falciparum. Are you familiar with Babesia, Leishmania, and Trypanosome anemia as well? The stat emergency when we have excessive red blood cell loss, that's the acute hemorrhagic anemia. Some normocytic anemias have a normal or decreased retic count, and these include the plastic anemias, anemia renal disease, and chronic inflammation, and myelophthisic anemia. And microcytic anemias, MCV less than 76, the most common one is iron deficiency anemia, but there's also anemia of chronic inflammation, thalassemia, hemoglobin E disease. Sideroblastic anemias include the hereditary and acquired, like lead poisoning, and drugs and toxins can also cause a sideroblastic anemia. The macrocytic anemias have an MCV greater than 100, and these are the megaloblastic anemias. You're familiar with B12 and folate deficiency causing a macrocytic megaloblastic anemia. There are also erythroleukemia, myelodysplasia, aplastic anemia, anemia of chronic liver disease, and alcoholism. In summary, here are the anemias according to MCV. We see the different anemias all categorized neatly under microcytic, normocytic, and macrocytic categories. And from there, the clinician should consider further workup based on diagnostic criteria and algorithms. Oh, wow, not all of these tests will be ordered and not all at one time. And I'm sure you're familiar with most of these tests, and I hope to review most of these tests in future videos. Stay tuned. I would like to bring your attention to the ASCP Board Certification Study Guide, where question styles vary, and I'll give you a few examples. Well, that concludes the presentation, which certainly has been interesting and fun. And I hope that it has been helpful for your learning journey. And I look forward to the next video.